First, I would like to thank Saleh for his kind invitation and the administration in Ibra Hospital for their organization of this workshop. And I was asked to present two topics about patient blood management and the clinical practices. And this will be my first part. But before I start, I want to give you a brief introduction about the work at the Department of Blood Bank Services, so that you know what activities we are doing, and to give you a better understanding where to find help if you need to communicate with anyone. So my understanding here, we have doctors, right, and nurses, lab scientists. Okay, doctors from gynae, any? No obstetrics? And emergency? From emergency, okay, good. Pediatrics? I think, yeah, we have pediatricians here. Anyway, so what we are currently having at the Department of Blood Bank Services, we have four main sections. The donor affairs section, which is responsible of looking and recruiting for blood donors and for donor retention, organizing all the blood drives, blood campaigns to maintain our inventory. And there is the central blood bank section, which has two arms: the laboratory for all the screening and the investigation, and the donor side, where doctors, nurses, and medical orderlies are taking care of the whole donation process and collection of blood, bringing the blood back to the center for testing. And then we have quality section, which is responsible of maintaining all the documents, standard operating procedures, validation protocols, and document control. And then comes the regional blood bank section, which form a way of communication between us and all blood banks like Ibra Hospital, from Suhar, Musandam up to Saleh. All blood banks communicate for the need of reagents, equipments, and for advisory role as well. So if for any reason you think you need some consultation through the blood bank, everyone can communicate with the Department of Blood Bank Services. So let's talk about patient blood management. First, we listen that to Dr. Ahmed Kashif. Collection of blood is not just a straightforward procedure. It needs to be controlled, monitored, temperature, timing, storage is very important, and screening also. So my presentation here will focus on one primary aspect: patient blood management, what it means, and what are alternatives to blood transfusion. Can we treat the patient in any other way other than giving him the blood? Blood transfusion should be our last solution. And then preoperative hemoglobin optimization, especially for patients going for elective surgeries. Transfusion of major hemorrhage, what we call massive transfusion. It can happen in emergency, in operating theaters, in obs and gynae, postpartum hemorrhage, for example, and transfusion in the ICU and in obstetric practice. I will start with the definition of patient's blood management, what it means to you. So the American Association of Blood Banks, the AABB, defines patient blood management as an evidence-based, multidisciplinary approach to optimizing the care of patients who might need transfusion. And this has three main pillars. Patient blood management requires an appropriate indication. So that's the evidence-based part. You have to know your indications of blood transfusions, whether it is red blood cell transfusion, platelet transfusion, or plasma, cryoprecipitate. IVIG is considered part of blood transfusion also, albumin as well, and all these plasma fractionation products actually comes under the scope of blood products and plasma fractionations. Then the most important thing also is to try and minimize the blood loss, to avoid the need for blood transfusion, and optimizing the patient red cell mass, especially prior to any elective surgery. If you have time and you can improve the patient hemoglobin, then go for optimizing the hemoglobin rather than waiting for the patient to need blood transfusion. As I said, blood can save life, but it also has some risk. So that's what we are talking about in this topic. Blood, we know that it is a life-saving treatment, and it is a very important part of many surgical and medical management. Especially nowadays, we have all these patients on chemotherapy. We have advanced surgical interventions. These managements could have not been successful without a proper support from the blood bank and the blood transfusion services. However, our problem is with the cost of blood. Blood is not cheap. Like looking for all the blood donors, all the testing and all the storage, the transport, all the procedures involved cost millions of riyals every year. And more than that, it can have some serious adverse effects. And of course, it is not always available. There will be many times where you want blood for your patient and the blood bank will say we don't have blood for you. For that blood group, for example, or for platelets, it's always short in supply. Therefore, avoiding unnecessary and inappropriate transfusion is both good for the patient and for the transfusion services for the health establishments. And it should be based on clinical assessment on individual patients' needs, not just based on laboratory tests. It's not that you are treating a hemoglobin value. You should evaluate the patient's actual need for blood transfusion. And it should be, the decision should be made on appropriate clinical assessment of the patient himself. Patients' blood management can improve patients' outcomes by helping to avoid transfusion. In many scenarios, if you are faced with a patient having adverse reactions and investigations go back to why actually he received blood transfusion, in many scenarios you will find out that this patient actually didn't require that much of blood to be given at the first place. And then it is the doctor who ordered this blood that has to scratch his head again. For next time, you think twice before ordering blood, because if this patient really doesn't need that blood, it may actually harm the patient. The other reason, hospitals who has a very well organized patient blood management programs can reduce blood transfusion from up to 50 to 70%, especially in orthopedic and in major surgeries. And blood transfusion, as I said again and again, it is inherently hazardous, regardless of what screening test you will do, what virology markers you will test for, but there are other non-infectious transfusion reactions that can happen, and it is not preventable. You don't know which patient will react to a platelet unit, for example, or which patient will have a transfusion reaction because of inappropriate patient identification. And today we'll have a very important discussion about transfusion reaction. It will be presented by Dr. Altaf. So you will see what's the magnitude of risk that this blood can carry to your patient. Now, just to give you an international perspective of what's the meaning of patient blood management, I will leave you with this small short video, if it works.
Transfusions are so ingrained in clinical practice that in many clinical situations, a significant number are given to alleviate physician's discomfort rather than care for the patient's needs.
Transfusion practice is based on behavior rather than evidence. We really must change transfusion medicine practice. There is no other alternative, and there is a sense of urgency. This change will be from a product focus to a patient focus, and this is what we're referring to as patient blood management.
In 2006, Tinmouth and colleagues analysed the association between red blood cell transfusions and increased mortality and morbidity in the critically ill. They wrote, "We have witnessed a dramatic paradigm shift, whereby red blood cell transfusions, once regarded as one of the great advances in modern medicine, are now considered harmful in some clinical situations." In 42 of the 45 studies that Marek and Corwin reviewed in 2008, they found the risk of red cell transfusion outweighed the benefits. The risk was neutral in 2 studies, and the benefits outweighed the risks in only a subgroup of 1 study. They concluded, "Our analysis suggests that in adult, intensive care unit, trauma and surgical patients, red blood cell transfusions are associated with increased morbidity and mortality, and therefore current transfusion practices may require re-evaluation." In 2009, the first International Consensus Conference on Transfusion Outcomes considered the benefits of transfusions across a total of 495 studies.
The findings indicated that in 59% of clinical scenarios, transfusions were not beneficial at all. In 29% of the cases, it was uncertain whether these transfusions were beneficial. It was only in 12% of this populations that transfusions were deemed to be helpful.
Blood is a complex biological fluid. A great deal of work has been done to understand the multiple biochemical and biomechanical changes that take place once it is removed from its host and stored. However, the possible clinical implications of transfusing this stored biological product are only beginning to be better understood. Dr. Andreas Meyer-Hellmann and colleagues from the Helios Clinic, Erfurt, Germany, used a cytoscan to film the sublingual microcirculation pre- and post-transfusion in a patient with severe gastrointestinal bleeding. The patient's hemoglobin fell to 2.8 grams per deciliter. This video shows the microcirculation after initial resuscitation with an acellular volume expander. What red blood cells are left are circulating through all the multi-cell and single-cell capillaries. The next video shows the same microcirculation after the transfusion of 3 units of stored allogeneic red blood cells. Clearly, here there is reduced flow. Single-cell capillaries are swollen. There is uneven distribution of the red cells, blockage and sludging, and many areas where there are no red blood cells in contact with the tissues. This work starts to provide insights into the possible mechanisms underlying the limited evidence for transfusion efficacy.
As clinicians, we have learned 3 key lessons. First, even the most profound anemia can be sustainably and quickly corrected without utilizing allogeneic blood products. Second, perioperative blood loss, even in complex procedures, can be significantly reduced. And third, post-operative treatment of asymptomatic anemia should be applied universally to sufficiently restore the patient's endogenous red cell volume.
It really is a sobering thought when one considers that allogeneic blood transfusion has the potential for a wider range of adverse clinical outcomes than probably any other medical intervention.
After considering all available evidence on transfusion and outcome, we are left with the conclusion that transfusion is a major multiplier of morbidity and mortality. Maintaining the status quo, as we see in transfusion practice today, would just not be accepted or tolerated in any other field of medicine in the context of current safety and quality standards.
Okay, so what I wanted to show you from that video, that you should not take blood transfusion as granted. It's not always useful for your patients. You should consider it as a very expensive and dangerous drug. And for any drug you want to use in your patients, you have to understand it is made when and how, and also what are the side effects that can result, and when to actually prescribe it for your patient. Therefore, the next step in my presentation will be discussing of what alternatives we can do to reduce the need for blood transfusion and save the patients all the trouble that they can have. In alternatives to blood transfusion, I will discuss about 3 very important aspects or approaches. The first is autologous blood transfusion, which means simply collection and reinfusion of the patient's own red blood cells, but there are different ways. Some ways are useful and recommended, and other methods are not recommended nowadays. We'll have a quick discussion. And then some pharmacological, some medical interventions that you can use to reduce the need for blood transfusion, and then IV iron at the end. So in regard to autologous blood transfusion, which I said is a collection of the patient's own red blood cells prior to the surgery, for example, and then giving it to the patient. That's what is called pre-deposit autologous blood transfusion. It was famous in the early 1980s for the reason we have mentioned before. For doctors and patients in the 1980s were afraid from the HIV infection, because that's when HIV started to appear, and everyone was not clear what is this serious infection is due to what, and how to test for it. There was no test for it, and it was transmitted quickly through blood receiving patients, especially hemophilia patients in those days. So at those years, doctors and patients asked for their own blood only to be used. That was recommended in those days, but nowadays it is no longer recommended because it has its own problems, and it's outside the scope of this presentation. But as I can tell you, it is very rarely used nowadays that we ask the patient to give blood donation and then use his own blood for himself. However, there are more advanced way of autologous blood transfusion. One type is intraoperative blood transfusion, and this is simply, and it is available in Oman, especially in cardiac surgery. This is using special equipped machines that collect all the blood oozing from the patient during the surgery, just do some washing and filtering, and bring the blood back to the patient. And it has improved the patient's outcomes and reduced the need for allogenic blood transfusion. Allogenic blood means blood from other donors. There is also post-operative cell salvage, which again is used mainly in orthopedic surgeries, where there is a high volume of blood drainage after hip or knee surgery, for example. There are equipped machines to take this blood, do it processing, cleaning, washing, and filtering, and then bring it back to the patient. Why science has looked for these approaches? Because of first trying to reduce the need for blood transfusion, and second because there are other religious blood groups like Jehovah's Witnesses, for example, that they never accept blood transfusion even if they are going to die from severe bleeding. And those religious groups are available around the world, in the West, in Europe, in North America, perhaps in Asia as well. So there are a group of people, and they are very well organized. They have their own lawyers that they will run after the doctor, saying, even if my child bled to death in the surgery, I will never allow him to receive blood, because for them receiving blood is like contaminating your soul, and then he will be kicked out of the community. It is very serious. So then there are other ways to avoid transfusing such patients by optimizing their hemoglobin, by giving them medicines that I will discuss to reduce the bleeding during the surgery, or many of them can accept this intraoperative cell salvage because this blood will be considered not going out. It's the same patient for the patient going through the operation and coming back to him. Then we'll talk about some medicines that you can use before or during the surgery to minimize the blood loss, to minimize bleeding. And I will start with tranexamic acid, which is very commonly available almost in all hospitals. It is very cheap and used widely for many indications. It is a lysine derivative that prevents change of plasmin to plasminogen, so it is an anti-fibrinolysis medicine. And it is low cost and can be used by oral or IV. It has very good results from systematic review of trials. And it has been found that it reduced the risk of receiving blood transfusion by around 30%, and the need for further surgery due to rebleeding as well. There is a small risk of thromboembolic events that cannot be excluded, and you have to know your contraindications when not to use tranexamic acid, for example in hematuria. Otherwise, these risks are not very serious and are not common as well. And this drug is used widely nowadays. And it is most effective if it is used in the first 3 hours from the onset of bleeding. So where it has been used currently, most of the large studies like the woman and the crash study here, the woman study is a very large study in obstetrics, postpartum hemorrhage, and they found very good results with this tranexamic acid, especially if they used it early. And the crash is in trauma patients with multi-trauma bleeding patients. Again, tranexamic acid, if used early in the first few hours, it can reduce the risk of bleeding and reduce the need for blood transfusion. So here is a drug that is cheap, very known side effects, very well controlled, and it can reduce the need for blood transfusion. There are other medicines like abrotenine, which is mainly used for cardiac surgery. Well, you are not doing cardiac surgery here in Ibra, but this drug has been used for some time, especially in open heart surgeries. However, it has more side effects than tranexamic acid. It was stopped in 2007 for some data showing it increases the risk of stroke and increases even mortality, but now it's coming back with alternative usage, so it is gaining popularity again, and especially for emergency doctors who are dealing with thrombolizing MI patients, this can be a very useful drug. Again, I don't think it's available currently in the Ministry of Health, but you have to know about it. Tissue sealants, they are also called biological glues or tissue adhesives. They are simply sometimes sprays of fibrinogen, and even this fibrinogen can be mixed with thrombin and get activated. It is also very useful, and it has been used in orthopedic surgeries. It stops bleeding, especially of connective tissue bleeding. Recombinant factor 7 or Novo 7. Is it available here in Ibra? No. So this is a very expensive but yet a very important medicine. Is it available in Suha? You think? On request. But it's not stocked in the... Okay. So this is one of the medicines that have a major role in massive transfusion, for example, whether it's intraoperatively or in trauma patients or intracranial hemorrhage. Recombinant factor 7, it's a coagulation factor, but it is a very potent thrombin generation factor, and it bypasses other factors. It is licensed for the treatment of bleeding patients with acquired hemophilia A and B, but more than 95% of its use worldwide is off-label use in patients with major hemorrhage. It is not licensed per se because it is a very expensive drug, but it it is used widely in reducing the massive hemorrhage risk, especially for patients with intracranial hemorrhage. It has been used in cardiac surgery, trauma, intracranial hemorrhage, liver abdominal surgery, and it is extremely expensive, so you need authorization from consultant hematologist to use this drug. Then the other drug is erythropoiesis stimulating agents, or erythropoietin. If we have renal doctors here, they usually use this medicine, especially in patients with chronic renal failure and anemia of chronic disease, because erythropoietin is normally produced by the kidney and increases blood cell production in response to hypooxygenation. And there is a recombinant form of erythropoietin, which was initially licensed for treating anemia and renal failure, and there are other longer acting forms of this drug that are used in anemia of chronic disease and cancer patients on chemotherapy. This is the last drug that I will talk about today, and I specifically brought this medicine because it should be considered, I think, more than the current situation. Parenteral iron, or IV iron. Anyone use IV iron in this hospital? You are? Good. Because the history is little bit confusing. It is known for its serious side effects that can be very severe allergic effects, but those are with the old forms, especially with the dextran formulas. But the newer formulas have less side effects. And the usefulness of IV iron is that it replenishes iron quite quickly, and especially in pregnant ladies who have intolerance to oral iron, or they have very bad stomach side effects. This drug can be very useful, and it is for sure less harmful than giving blood transfusion for a patient, because it can raise up the hemoglobin quite fast and alleviate all the symptoms from the chest pain, dizziness that happens with the pregnant lady because of anemia. And at the same time, you don't have to give the patient all that blood with its inherited risk of infections, of transfusion reactions, and other risk. So I will highly recommend that you look into the IV iron usage and optimize it for your patient, not only maternal anemia or obstetric anemia, but also for preoperative management. The common, this is not working now. The common indications for IV iron include iron deficiency anemia with intolerance of oral iron, if the patient cannot take oral iron because of side effects, and especially if the absorption of the iron is also affected, like in inflammatory bowel disease, then the use of IV iron is very useful. Then also to support the use of erythropoietin. Patients on renal dialysis, they can develop anemia of chronic disease for many reasons, but it's not enough just to give erythropoietin. Thank you. Sometimes you need to support the erythropoietin with IV iron. Actually, most of the cases would require IV iron with erythropoietin. Otherwise, erythropoietin itself will not improve the erythropoiesis. And it can be used as an alternative to blood transfusion when a rapid increase in hemoglobin is required, especially for preoperative anemia, severe anemia in late pregnancy, or postpartum hemorrhage or postpartum anemia. So obstetrics, they should use this drug quite often, especially for ladies who cannot take oral iron for side effects. Let's talk about preoperative hemoglobin assessment and optimization. This is one way, if you want to avoid blood transfusion and you have an elective surgery like after 1 month, then you have the time to improve the patient hemoglobin. This is just one example of a protocol that you can use, and it has this one is used in Australia, for example. If you search about pre-operative hemoglobin optimization, you will find several examples. You can read about it. You can find the UK guidelines, North American, Canadian, USA. This Australian, and brought it because it's quite simple. So it simply has to do about doing the test pre-surgical and looking for the CBC, doing the iron studies, including ferritin and CRP and renal function. So if there is anemia, which is hemoglobin less than 13 or for men, or hemoglobin less than 12 for women, if there is anemia, then you have to find out what's the cause of this anemia. Is it because of iron deficiency anemia? Then simply you treat it with iron supplement, whether it is oral iron, or if you have if you have longer time until the surgery, or you can give even IV iron and try to avoid all the need for blood transfusions, whether it's not available or may cause some side effects. And it also, you may identify an anemia of chronic disease, in which you have to evaluate why this patient has anemia of chronic disease. Is it because of renal impairment? Is it because of other reasons? And then you can consult your hematologist or physician. The rationale of patient blood management in peri-operative setting. Peri-operative anemia is common. It can be up to 11 to 76% of patients going for surgeries, they can be anemic. Because usually who goes for surgery? It's either an elderly or a patient with some chronic problem, and the human system acts all together. So anemia is a common finding in pre-operative setting, and it is even more common after the surgery. Peri-operative anemia is associated with adverse outcomes, including mortality. If you are putting a patient with anemia into any kind of surgery, it has been found from studies that the mortality and morbidity is higher from a patient that has a normal or near normal hemoglobin level. And on the other side also, if you just give blood transfusion pre-operatively to a patient going for surgery and you transfuse him blood, there are also studies that will say patients going for surgery who receive blood transfusion also has a worse outcome than patients who went for surgery without receiving blood. So the risk is there. Try to treat it medically. It's better than giving it blood transfusion. How you can do that? First, diagnose and treat the cause of pre-operative anemia, and know your appropriate indications of blood products. Reduction in unnecessary phlebotomy, especially in ICU patients. Lots of blood samples every day, morning and night, and every 2 hours sometimes can lead to iatrogenic anemia. And then try to have minimally invasive surgery instead of going for open surgery, abdominal surgery. See if you can do it by laparoscopy, for example, to minimize the blood loss. Use good surgical techniques, and if you have intraoperative cell salvage, it's also useful. The use of hemostatic agents or antifibrinolytic agents like tranexamic acid and other medications that we have discussed, and timely discontinuation or reversal of anticoagulation like heparin or warfarin. If your patient is on heparin or warfarin as going for surgery and you forgot to stop that medicine, he can bleed to death. So that's a very important aspect of pre-operative assessment of your patients. You assess the anemia and the risk for bleeding as well. Now in the few minutes left, I will discuss about some clinical aspects of blood transfusion. I know these topics can be a little bit congested, but it's just to give you a headline or an overview of the subject so that you can go and read around it according to your specialty, your area of work. So let's talk a little bit about massive transfusion. And here is a very busy slide, but I will just explain it in simple terms. Massive transfusion is a serious situation, and you need to know when to deal with your patient as a massive transfusion, if he is in the operating theater or he is coming with an RTA, for example, in trauma patients. So there are guidelines that I will discuss when to initiate the massive transfusion protocol. But what I want to say that each hospital should have a massive transfusion protocol. They should have a transfusion committee that involves the laboratory, involves the physicians from all specialties, medical, pediatric, obstetrics, anesthesia should be there, in charge nurses to organize the things also. So a transfusion committee, one of its responsibility is to develop massive transfusion. And I think Ibra Hospital is an area that receives lots of RTAs. That could be a serious situation, and if it is not well organized, things can go wrong at any step of the chain that we discussed with Dr. Al-Kashif. So for massive transfusion, you have to monitor your patients closely and then activate the massive transfusion protocol so that the blood bank knows that there is a patient who requires lots of blood transfusion. And usually the doctors or a senior clinician involved with the case will request for 4 units of blood, 2 units of plasma, and maybe platelets if the platelets are also low. So what's the aim of treatment in massive transfusion? You have to think about 2 main things. First, to maintain the oxygen supply to the vital organs, brain, kidneys, liver, to avoid multi-organ failure. And also you have to avoid DIC. Remember, the patient is bleeding. He's not losing only red cells. He's losing coagulation factors in the plasma. He's losing platelets. So all of these need to be replaced. And that's why you should have a protocol to know what blood product you ask for. In some centers, they only transfuse red cells and they forgot about plasma and platelets, for example. There are other important aspects you have to think in massive transfusion other than blood collection or blood transfusion. Oxygenation, you have to maintain the oxygenation, cardiac output, and the metabolic state. If the patient is in acidemia, his enzymes, his factors will not work. So you have to correct the metabolic imbalance. And also hypothermia. If the patient is bleeding a lot, he will lose temperature, he will be hypothermic. Hypothermia, if you are giving plasma or red cells, whatever, it will not be useful if the patient is in a very cold state. This is perhaps more common in the West because our environment here is not that cold and there is no snow and so on during the RTAs. But also you have to think about it because also you are transfusing blood that is cold temperature. It comes out of the temperature out of the fridge at a temperature of 4 degrees only. And if you are giving lots of blood, that patient will lose his temperature quickly. I will just save you the trouble, and maybe you can go back because these are busy slides, and I just wanted to give you some hint that the massive transfusion protocol is important in any hospital, especially in trauma hospitals. Then transfusion in ICU setting or critical care. It is also an area that more than 50% of patients admitted to ICU are usually anemic for many reasons. But the main reasons are either hemorrhage, hemodilution from IV fluids, or frequent blood sampling. Or there could be also anemia of chronic disease, anemia because of the underlying condition of the patient himself. So this diagram only will give you a brief overview of how you should manage a patient in the ICU. Why? Because there has been important clinical trials about blood transfusion in critical ill patients. And they found out that maintaining a lowish hemoglobin is actually better for the patient himself. There is a famous trick trial that they found out if the patients maintain a hemoglobin around 70 to 90, he has better outcome after discharge from ICU than transfusing to a higher threshold of hemoglobin. And they think that is because of the other associated risk of thromboembolic, or even the adverse events from the blood transfusion. So if the hemoglobin in the ICU patient is above 90, then do not transfuse. See, so don't transfuse your patients up to 12, 13, aiming for a normal hemoglobin level. Good. So hemoglobin around 90 should not be transfused, and for patients who are actually having other problems like acute coronary syndrome or severe sepsis, then you have to consider a little bit a higher target hemoglobin. Only elderly patients with sepsis and with severe neurological injury, you can consider a higher hemoglobin level. Okay? Remember, for the elderlies, they may not have the same tolerance to anemia. So this group of patients, especially elderly with congestive heart disease, then you may aim for 80 to 90. Otherwise, general critical care, use default hemoglobin trigger if less than 70 only. And you should not transfuse to up to 10 or above 10. Is that clear? So hemoglobin threshold in ICU should be below 70. You only transfuse if the hemoglobin dropped below 70, except in elderly patients or patients with cardiac disease. And your aim of transfusion should not exceed 70 to 90. You don't aim for 11 or 10 or 12 or 13, because that has its own risk. And there are big trials saying that actually the outcome of patients receiving blood transfusions to hemoglobin level above 10 have worse outcome. You are not helping your patients. Then we'll come to platelet transfusion in the ICU. If the patient is not bleeding and he has no sepsis and there is no coagulation problems, platelets are not indicated. When they are indicated, if platelets drops below 20, and that's a figure that many doctors don't accept, especially in obstetrics and other, because the normal platelet range is 150 to 450. 20 seems to be way down from that normal level, but it has been known that spontaneous bleeding in otherwise no other risk for the patient will not happen if the platelets are above 30, for example. So only you transfuse platelets if they drop below 20. Except in DIC with bleeding, platelets should be maintained above 50, and if there is this major hemorrhage, you maintain at 75. And there is one more aspect, yes, if multiple trauma or CNS or eye trauma in the ICU, it should be maintained at a higher level. So platelets, you don't ask for platelets except if they drop below 20, unless there is a CNS or eye trauma or bleeding. Plasma has its own indications, and it is indicated especially for patients with DIC or factor deficiency. But remember, here is where we find lots of confusion happens. The dose is about 15 ml per kg. And if you really want to transfuse plasma to your patient, you have to give him appropriate dose, otherwise it will not work. Many requests come like, we want 2 units of plasma for our patients. That's not useful. You either transfuse the real dose, the required dose, or you don't transfuse plasma. And many studies, they found that plasma transfusions are not based on appropriate indications. INR is not that high, and there is no clear, even there is no bleeding. In many studies, they found most of the requests, there was no actual bleeding. In liver disease, you have to be careful, because liver disease produce the clotting and the anticoagulant factors both. So in liver disease, there is an abnormal coagulation, but the patient is in a state of balanced coagulation state. Like, it is not normal, but both sides of the balance are there. It's the clotting factors and the anti-clotting factors are not produced. So unless there is bleeding in liver disease, you should not play with his coagulation factors. So if you give some more coagulation factors, then you may expose the patient to risk of thrombosis. It's a very changing medicine, especially with liver disease. Cryoprecipitate can be used for DIC patients and in severe liver disease also, and especially if fibrinogen is going below. Gynae doctors, they use cryo more often because if there is postpartum hemorrhage, fibrinogen tends to go down quickly. So I discussed some aspects of the obstetric practice. That's my last discussion, but I want to emphasize on the subject that oral iron replacement is appropriate for most patients, but actually IV iron could be needed if the patient is not tolerating the oral iron, and transfusion is rarely required in hemodynamically stable pregnant women with hemoglobin above 70 unless there is active bleeding or high risk of bleeding. And again, it's better to treat the anemia rather than give blood transfusion. Here, I want to raise the issue of well-organized multidisciplinary protocols for postpartum hemorrhage, and remember to use your medications like tranexamic acid, and if you have the cell salvage, which I don't think it's available currently in Ibra, but it is there in Oman, the use of administration of tranexamic acid is also very important in postpartum hemorrhage. So remember that the answer is not always blood transfusion. And you have to know about hemolytic disease of fetus and newborn. That's a whole subject by itself. I'm sure pediatricians, neonatologists, and obstetric and gynecology, they have a very good understanding of this topic. Anti-D prophylaxis have improved the outcome a lot, and that's the end of the first part of my presentation. I think we have a discussion session, and then after the break we'll continue, inshallah. Thank you very much. So it's time for questions.